All right, good morning, everyone. Appreciate you all being here for our Kaiser County meet and greet on the child welfare side. My name is Beljeet Hundal, and I'm your CWDA and CFPIC CalAIM consultant. And I'm going to help facilitate this meeting today. Most of it is going to be a presentation by Kaiser, and then we are going to do a question and answer period at the end. However, during the presentation, if you have questions that are coming up, you can either put them in the chat or you can raise your hand and we will stop to take your question. We want to, allow this as a flowing conversation and discussion as well. So anyway, I'm going to hand it over to Andrea to provide some introductions from the CFPIC side.
Great. Good morning, everybody. I'm Andrea Sobrato with CFPIC, and I also want to recognize Laura and Peter from my team as well at CFPIC. We're really happy to sponsor this meet and greet with Kaiser for our northern counties. And I wanted to just let you know that the recording and the PowerPoint and a follow-up document of frequently asked questions will be posted on our website. So if you have colleagues that weren't able to attend, you will be able to find that by next week on our website. With that said, I would love to turn it on over to Kaiser.
Thank you so much, and good morning, everyone. We're so happy to be here with you all, and we've got a really awesome team here to represent KP and to really start to share a little bit more about our program, and really look forward to hearing from you all and continuing to build the relationships and share some of the work that we've been doing, to really. Oh, can you all hear me?
In meetings all day, but I'm not talking.
Oh, looks like maybe there's some feedback. All right. Well, just to start off with an introduction, my name is Vanessa Davis, and I'm a director with our Medi-Cal program. I oversee our external engagement and other strategic initiatives, including some of the incentive payment program work that we're doing in collaboration with DHCS and many of our community stakeholders. So we can advance the slides. So today we will just do some brief introductions. I will provide a high-level overview of Kaiser Permanente's Medi-Cal program, and then we'll spend some time on MOU execution and implementation. From there, we'll move on to some child welfare highlights. We have our child welfare liaison, Ola, here to kind of give us a deep dive there, and then we'll make sure that there's plenty of time for questions and answers. I see a hand. Jessica, did you want to jump in? Or is it an accidental hand? All right.
Accidental, sorry.
Okay, no problem. All right, let's keep moving. So again, my name is Vanessa Davis. I'm a director with our Medi-Cal program. I've been with Kaiser for over a decade in a variety of different roles, primarily in the community benefit and community health space, but really honored and excited to have joined the Medicaid team earlier this year in January. And we're also joined by Roger and Ola. I don't know, Roger, if you want to say a quick hello, and Ola.
Hey, good morning, everybody. Thank you so much. Thank you, Vanessa. My name is Roger Tang. Very much so looking forward to having the conversation with you all today. And, thank you all again for allowing us the time and space for this. I'm joined by a couple members of my team that you'll meet, but my counterpart in Southern California, and similar to Vanessa, I think I joined in April, so relatively new to the group. And as well as Lev, who is our contract manager, who I think you'll particularly want to hear from as she covers child welfare and IHSS. And with that, I will pass it to Ola.
Good morning. Can everyone hear me? Awesome. So I'm Ola Ajibola-Stott. I've been with KP since the beginning of this year, and I've been serving as the child welfare liaison since about February. But prior to coming to Kaiser, I do have a wealth of knowledge. I've worked with a residential treatment facility for 8 years, last 2 years with their transitional aged youth. I've also worked with Eastern Southern California, I've also helped to set up a regional crisis program in Virginia, and I've also worked with the Native Hawaiian healthcare system in Hawaii. So I do have a wealth of experience working with youth and their families, and really navigating complex healthcare needs. And so happy to be here and happy to support our child welfare and foster youth at KP. And I am joined by several different folks on my team as well. And I also have Gina Annixter that I'd like to introduce to the call. So Gina, do you mind just sharing, just introducing yourself?
Can you hear me okay?
Yes.
Okay, thank you. It's always tricky to unmute. Good morning, everyone. My name is Gina Annixter, and I am the Director of CCS and Complex Youth for Kaiser Permanente. I've worked with Kaiser since 1990, so obviously I know Kaiser Permanente quite well. I'm new to the foster youth space, but very excited to take on all the responsibilities that come my way. So thanks for having me.
Awesome. So thank you. I just wanted to introduce Gina as she is leading some of the foster youth model of care for Kaiser. And I work very closely with Gina as we work on our future state with child welfare. So thank you. Turning it back over to you, Vanessa.
Right. And as Roger teed up and Ola mentioned, we've got several other KP folks on the call who I'm sure you'll be hearing from during the QA portion of the agenda. All right, so just to ground us in Kaiser Permanente's mission, we really exist to provide high quality, affordable healthcare services and to improve the health of our members and the communities that we serve. And this has been our mission for over 75 years. And I really want to underscore that this last piece around the communities that we serve, it is really core to our mission. And this is where a lot of our commitments to our Medi-Cal program live. I think with some of the changes that you all are likely very aware of that took place earlier this year with the transition to the direct contract, we have an opportunity now to deepen our relationships with community stakeholders, county agencies, and others, community-based organizations. And we're really excited to really double down on this commitment through our Medi-Cal program. So just wanted to kind of underscore that this is a critical part of our mission and the work that we're doing collectively with you all today. So effective earlier this year, 1/1/24, Kaiser Permanente did go into a direct contract with the California Department of Healthcare Services, or DHCS, really to provide coverage and care for Medi-Cal enrollees in 32 California counties. Just to kind of highlight some of the changes, essentially this is enabling Kaiser to expand our Medi-Cal services from 22 to 32 counties, allows KP to offer Medi-Cal coverage in all the areas of the state where we had previously offered commercial healthcare coverage to really ensure that continuity of care for our members as they may transition from one insurance line to another, and then extends access to Kaiser Permanente's care, including specialty care to non-members in selected areas through some really innovative pilots in close partnership with many community partners through the Population Health Management Initiative. So wanted to kind of highlight some of those core changes that went into effect with the advent of the direct contract. We can advance. Thanks, Andrew. So this is just a snapshot of our statewide Medi-Cal coverage. You'll see the blue counties listed here are our Northern California counties, including some of those in the Central Valley, and then our Southern California membership and counties here. You'll see as of July, we have just over 1.1 million Kaiser Permanente Medi-Cal members. Next slide. Okay, so the following populations became eligible or are eligible to join Kaiser Permanente's Medi-Cal managed care plan effective earlier this year. So these are some of the buckets that really articulate who is eligible to become a KP Medi-Cal member. So the first bucket is really those who've had KP coverage within the past 12 months. And this is the most substantial portion of of our Medi-Cal members this year. So really, this is recognizing that, you know, a person may have been covered with KP through employer-sponsored coverage or through another line of business. And now if they are meeting eligibility requirements for Medi-Cal, they would be eligible to join KP Medi-Cal from the past 12 months. The second is our family linkages bucket. So those who are qualified family linkages of existing KP members are also eligible to become KP Medi-Cal members. Those who are foster youth and former foster youth, which you'll hear a little bit more about later today, and this is eligible up through age 26. And those who are duals, so covered by both Medicare and Medi-Cal. And this was another really important priority for DHCS to ensure that seamless integration of care. So if a member, say, was with KP as a Medicare Advantage member and they're eligible for Medi-Cal, they would now automatically be enrolled in KP Medi-Cal to ensure that integration of their Medicare and Medi-Cal services and benefits. So additionally, there is some growth through auto assignments or default enrollment. So for those beneficiaries who do not select a health plan, Kaiser Permanente is now participating in default enrollment or auto assignment, depending based on really capacity at the county level. So that varies at the county level. So we can advance. So I'm going to spend a little bit of time. I know you all have probably seen this and may be providers yourselves of some of these services, and certainly won't spend too much time here, but wanted to anchor us in a couple of different core benefits and services through CalAIM, and talk a little bit about Kaiser Permanente's approach to offering these services. So taking a look, so CalAIM, also now recently rebranded by DHCS to Medi-Cal Transformation, is a multi-year initiative by the California Department of Healthcare Services, really anchored in transforming the Medi-Cal program to improve health outcomes and address health disparities among Medi-Cal beneficiaries. There's 3 primary goals, which I'm not going to list here, but just suffice to say, CalAIM has multiple different programs within it. Sometimes I think we think CalAIM is only enhanced care management and community supports, but it's encompassing of multiple initiatives, including the Justice Involved strategy, the behavioral health, the path work that DHCS has been driving, but wanted to just ground us in kind of some of these the core focus of Medi-Cal Transformation, or CalAIM. So through the enhanced care management and community supports, really there are a new set of benefits and services that eligible Medi-Cal members are able to receive, including care management and some of these additional services. So if you think about Kaiser Permanente or a Medi-Cal member, really at the center, there's different levels of care management that the Medi-Cal member would be assigned to. There's basic population health management, complex care management, and enhanced care management. And this is based on kind of acuity of health and social needs. So enhanced care management is a benefit, a Medi-Cal benefit that's really focused on intensive, primarily in-person coordination of health and social and health-related services that is offered through a community-based provider. Complex care management and basic population health management are additional care management programs that are managed and provided internally by KP. So you'll note that on the right-hand side, we have these additional benefits and services also offered by community-based providers, including the community health worker benefit and community supports. And these community supports are really non-medical services to support health-related social needs. And these are things including housing-related services, medically tailored meals, other in-home services to support transitions to or an individual safely remaining in their home. And I wanted to just articulate that with enhanced care management, DHCS has a very prescriptive set of eligibility requirements that are standardized across all of the managed care plans. Community supports, while there are certainly eligibility requirements, any Medi-Cal member who meets those eligibility requirements is eligible to receive those community supports. So they can be a basic population health management, complex care management, or enhanced care management to be eligible to receive those community supports. So we can advance. Wanted to highlight here some innovative work that Kaiser Permanente is really excited to be a part of. One of the things that we've heard, particularly with regards to enhanced care management, but also true for community supports, is that there's a pretty low level of awareness in the community about what these benefits and services are. And DHCS has been really intentional and explicit that they want to see more of the enrollment in these programs being driven from the community, from providers in the community, from members themselves, in contrast to health plans doing kind of data mining to do proactive outreach. So again, there's different ways that a member can get enrolled in these services, but DHCS is really focused on driving community-based enrollments and referrals. So in order to raise community awareness of enhanced care management and drive referrals, Kaiser Permanente has been planning a communications approach, outreach strategy, leveraging a public health communications firm, the Public Good Project, for a trusted messenger campaign. The intent is really to evaluate an active and creative way using trusted messengers to increase overall community awareness of enhanced care management and drive referrals so that Kaiser Permanente, and other managed care plans can really ensure increased awareness, visibility, and ultimately enrollment into these programs. The messages are really targeting two populations of focus to start: the foster youth population of focus and birth equity populations of focus. And then we're really aiming to target or to launch this pilot in Q4. So absolutely excited to follow up with additional information. We're kind of in the active planning stages for this outreach campaign and have been engaging our PATH CPI facilitators and collaborators to get additional feedback and ensure we're being really thoughtful about our outreach strategy. So we can advance. All right, so Kaiser Permanente is taking what we call our network lead entity, or NLE, approach to support the development of a robust network of providers for enhanced care management, community supports, and the community health worker benefit across the 32 counties. The network lead entity really ensures a centralized coordination of services through these network lead entity partners, while Kaiser Permanente retains oversight of eligibility, member notifications, all quality oversight, and grievances. The network lead entity helps us ensure that we have comprehensive network coverage. We're really excited that we're able to offer almost all of the community supports. I think there's maybe one county where we're still working on sobering centers and recoup care, but all of the community supports, or all of the enhanced care management and community supports across the 32 counties. And the expertise of the network lead entities really ensure that we have that comprehensive coverage and can enable the timely access to these really critical services for our members. All of this is really fueled by collaboration with community-based partners. So the network lead entities provide these services through close collaboration with community-based organizations and other entities with geographic and population of focus expertise. So we can advance. The three network lead entities that have been selected after a very extensive and rigorous selection process last year are Full Circle Health Network with extensive expertise in working with children, youth, young adults, and families. Independent Living Systems, or ILS, a longstanding enhanced care management and community supports provider with Kaiser Permanente and other managed care plans. And then Partners in Care Foundation, who is primarily focused in Southern California with additional expertise and experience serving as a network lead entity. So if we can advance. Finally, for those community-based providers who may be interested in becoming part of the network lead entity network to serve KP Medi-Cal members, these are the outreach and contact information for the 3 NLEs. So for those who would be interested in becoming part of the network, you would send an email to the appropriate entity specifying the services your organization or agency provides, the geography, and then population expertise. I know we have Andrew Tsang from my team here, and others from KP are also happy to facilitate those connections. So if you are interested or do have any questions for follow-up, we'll make sure that you all have our email and contact information. I'm seeing a question about if a county child welfare services department wanted to become an ECM provider, they would go through Full Circle Health Network. That's correct. We have worked really hard to create a no wrong door approach for referrals for enhanced care management and community supports. Referrals are accepted from any source. So the member themselves, family, providers in the community, other community-based organizations, and they can be placed via email or phone. So we have the information and with links to a referral form for our Northern California counties, as well as our Southern California counties, and are really happy that we've created a really seamless process for making sure that anyone who may be eligible for these services can get connected. Okay, I think we can advance here. This is, again, we just wanted you all to have a cheat sheet, helpful links and context document for KP Medi-Cal. So we have a link to our Medi-Cal Resource Center with some really helpful county level information that you can search for if you're interested in getting additional information for a particular county, information regarding our call center, and some of our other specific benefits and services. Yes, the note around the 4 counties having a shared referral process, this is for LA, Sacramento, Stanislaus, and San Diego. We've created a shared referral form. I should just caveat that this with, we will accept any referral form. It doesn't, so Kaiser Permanente can accept a referral form from another managed care plan. So if you happen to have a referral form or like a referral form from another managed care plan, we will accept that and we'll work with you to ensure we have the appropriate information. But the managed care plans collaborated in those 4 counties around a shared referral form. All right, I think we can advance. All right, I'm excited now to turn it over to my colleague Roger, who's going to talk a little bit about our journey with our MOUs, both from a planning and an implementation phase. And I'll continue to monitor the chat for questions as well. All right, Roger, I'll hand it over to you.
Thank you, Vanessa, and thank you, Andrew, for driving the deck. If we could start maybe with just a quick couple intros, if we move to the next slide. Thank you so much. So I'm joined by, like I said, on the Kaiser side, we're joined by our counterparts or teammates on the contract management side. So love, if you don't mind coming off mute and starting with a quick intro. I think team would love that.
Good morning, everyone. My name is Love Melichuk, and I'm the contract manager for IHSS and Child Welfare. And prior to joining the KP team, I actually worked at DHCS as a contract manager. And prior to that, I actually worked at a local county as an IHSS worker for over 7 years. So I got to kind of see the best of both worlds. And I'm really happy and excited to be here and have this presentation for you guys. On our team, we also have Emily Daniel. She's our senior manager with Medi-Cal Contract Management. We have Roger, and I'll pass it on back to you to introduce our team.
Thank you, Love. So you guys see that we really are trying to bring you guys the best of the best. I am the senior manager of the Northern California side. I'm joined by my counterpart, Lana, who is the senior manager on our Southern California team, and our regional director is Shazad Danani. So we're just wanting to leave our contact information here in case any questions arise after the meeting. But today, if we can move to the next slide, we'll start with just like kind of a brief overview of Kaiser's journey for today. I think a couple of these pieces were covered in Vanessa's presentation earlier, but if we can move to really, I think the next second box. So really up until January 1st of 2024, thank you so much. We move to the next box up until sorry, Andrew, back to the other one. But up until December 31st of this year, Kaiser's had operated as both with the direct contract and as a subcontract to the state of California. So what that looked like would be, in 5 geographically managed counties with a direct contract and 17 planned partner counties. For example, what that might have looked like would be, in Riverside County, we would have been with the IEHB, or in Santa Clara County, we would have been a planned partner through Santa Clara Family Health Plan. With the transition into January 1st of this year, we move to the next piece. Kaiser now has the direct contract and has assumed all managed care organization functions across all 32 counties where Kaiser maintains a commercial footprint. So essentially now the Medicaid footprint matches our general commercial footprint. And a part of this is it increases the continuity of care so that in the event that folks ever lose their commercial coverage, there does not have to be a lapse in their care plans or with their physicians. Moving into a little bit about what Kaiser has done up until this year. So earlier this year, with the creation of the MOU work group within Kaiser, it's really been intended to delineate the MCP responsibilities so that we can make sure that we have dedicated resources to support this work, this body of work across all 32 counties. With that said, we have our team, which focuses on the operationalization component, our implementation team. We're joined by a few MOU coordinators that I'll shout out a little bit later in the deck. But thank you guys for joining. And our execution team, which is Love and Emily's teams, which will drive the contract management component, going through the red lines, going through the conversations with all your teams and partners. And then from the ongoing coordination of care and the overall programmatic efforts, that's kind of where Ola and team really fit in and provide that expertise and that guidance across like these work streams outside of just MOU. In terms of where we're at today, we're continuing to make outreach to different counties, different county agencies and our partners, making progress towards the execution piece of getting the MOU signed. Internally, we're onboarding new team members. We'll go into a little bit of the structure of the team so that you'll know like who you would be potentially interfacing with or who you already have interfaced with, and bringing on new team members to really support this body of work and get ourselves ready to move into steady state operations. If we can move to the next slide. Thank you. So Love and I will tackle this one, but just wanted to go over, this is just intended to provide a brief overview of the MOU scope and objectives. If it's helpful to reiterate, Kaiser really prioritizes collaboration, and we seek to create mutually beneficial agreements when negotiating these MOUs. This not only ensures that we're in alignment with the requirements set forth by VHS, but also allows us to make sure that post-signature, we're building sustainable and efficient processes for implementation. Just a little bit in terms of the scope of work, the 9 MOU types that will be executed and operationalized across the 32 counties in California include, we'll just call out IHSS and child welfare, but you can see kind of the full portfolio of work. And with that, I'll hand it to Love to go over our objectives.
Thank you, Roger. So what are the objectives of the MOU? It is to clarify roles and responsibilities between MCPs and third-party entities. It's to support local engagement. It's to facilitate care coordination and information exchange for referrals. And finally, to improve transparency and accountability for service and care delivery. And who are the KP teams? They're the MOU contract management team, the program liaisons, the MOU implementation team, which are the MOU coordinators, and finally the PMG partners, which are the medical group clinical teams. And I'll pass it on to Roger. Next is going to be our MOU execution and implementation, which actually I will talk more into. Next slide, please. So as an MOU contract manager, these are our roles and responsibilities across the pillars of the KP MOU work group, and we all work together to help this MOU go smoothly. So as a MOU contract manager, we manage and contract negotiation, red lines, approvals, and signature execution. We report to DHCS on quarterly updates. And then post-execution, contract management team manages contract storage, posting for DHCS reporting, and ongoing maintenance. And now I'll pass it on to Roger for MOU coordinator role.
You love so far our MOU coordinators, where we sit within the MOU implementation team. So these folks are designated as in the MOU language by the MCP responsible party as the contractual MCP liaisons in all of our MOUs. They will serve as the primary point of contact for KP and our county partners post-execution, leading the implementation and operational efforts as a subject matter generalist. And that's where you'll see as we go into the other two quadrants, how we lean on this core operating model. Post-execution, our MOU coordinators, they'll facilitate, at minimum, quarterly meetings, manage the ongoing county relationships to ensure that in steady state operations, we are appropriately intaking and triaging requests from our partners before, redirecting as appropriate. Think of the MOU coordinators really as your forever person post-execution. This is like your central point of contact. They are going to be responsible for making sure that for their assigned counties, that they are able to provide the right resources and be that go-to person when it comes to, we still don't see this being a static process. It'll have to continually evolve and also address, any sort of changes, whether it comes from DHCS guidance or any sort of operational needs that change as we move into, steady state. The other two quadrants on the team would be our program liaisons who partner within our broader team, our care delivery and operations teams in their assigned domains. So whether that be WIC, LHD, IHSS, child welfare, for example, for today, and they would connect with our PMG partners on the care coordination workflows. And so you'll see that we're with this work group and with this model, we're leveraging both the expertise from our clinical side and from our operations regulatory components to make sure that we really are able to ensure high quality delivery of care across the board. And that's kind of a brief overview of the work group. We can move to the next slide. So I'll hand this back to you because this was where we'll cover execution and implementation and kind of what is going to be considered. How are we defining those processes?
Thank you, Roger. So before MOU is signed, the MOU contract managers at KP will collaborate with our external partners through the MOU scope, which is to define collaboration purpose and scope with all parties to begin collaboration. Then through a MOU kickoff, which is to facilitate kickoff discussions or meetings with all parties to begin MOU redline discussions. Through our MOU red lines, which are to draft, revise, and finalize MOU terms with all the parties towards execution to address requirement changes and establish amendment process. And through, and also contract managers are specialized by the MOU type, for example, IHSS, child welfare, and so on. And I'll pass it on back to Roger for the post-execution.
Thank you, Love. And so then for our what we're calling our post-execution phase, which is really the implementation component of the work. So after the MOU is signed, once again, think of the MOU coordinators as your central point of contact, and they will be your primary collaborators as we work through some of these pieces that you see on the screen. That includes training development. So the approach that we'll provide is that deliver initial MOU training materials to begin an iterative collaborative approach trainings with all of our parties. So that includes sort of an initial training deck 60 days after execution. Workflows and processes, we will guide all our stakeholders from across all the parties through these discussions to define the workflows and policies and procedures. Again, in the spirit of collaboration and communication, this is the establishment of minimum quarterly meetings to support the continuous ongoing relationship of this body of work. And the way our team is assigned, you'll see that each MOU coordinator is assigned to a subset of counties. So they really are going to be centralized points of contact post-execution. So it would be, designated one person to go to for kind of everything that runs the gamut as we go into the post-execution world of MOU. A couple of the coordinators I see on the call today. For Northern California, we see Emily Arianza is on. For Southern California, I think I see Giselle Fernandez is on. So just a little bit about a few folks that we have on the call as well today. So with that said, I think we'll move to our final section of this segment, which is just an overview of the MOU process, which I will hand back to Love to close us out.
Thank you. Next slide, please. And I apologize in advance. This might be a repetition for some of the counties because we usually present this at our kickoff meeting, but I'll go over all over it again. Our phase 1 is the redlining of the MOU. It's when the MOU contract manager schedules a kickoff meeting via KPMOU at kp.org, and then contract manager maintains execution tracker, leads MOU redlining, manages county MOU correspondence, obtains a SME or liaison feedback, and sends to legal for material changes. And all parties agree when the MOU is ready for signature. This also includes the county sending the red lines to their legal and getting their stakeholders' feedback. Phase 2 is the signing of the MOU. The contract manager identifies MOUs that are ready for signature and prepares all the necessary documents. Contract manager submits the pre-signature memo to signatory, and then contract manager facilitates the briefing meeting and sends approval MOUs for signature via Adobe Sign. And finally, phase 3 is the implementation of the MOU. Contract manager stores executed MOUs and related legal correspondence for future references, plans for annual updates. Contract manager team files executed MOUs with DHCS and posts to kp.org. And contract manager hands off to the MOU coordinator who schedules quarterly meetings and maintains the ongoing relationship in steady state. Next slide. And I'll pass it on to Ola, our child welfare liaison.
You love. Perfect. Can we advance to the next slide? All right, so again, I'm Ola Ajibola-Stott. I'm your child welfare liaison for all counties. And so I do like to share this slide as a just understanding of, we know that for the child welfare population, we have several different folks that are around them doing some work. And so I wanted to include all of our different divisions, all of our different departments internally and externally that we see as the core team for our foster youth and child welfare population. So to the top left, we have our county public health nurses. Then to the right of that, we have our behavioral health and county which could be our county or community organizations. Right underneath that, you have managed care, which is where I'm at as the child welfare foster youth liaison, and we also have healthcare coordinators that can be assigned to our child welfare and foster youth. Then we have our medical groups, our doctors, nurses, and social workers that are sitting in the different locations that are located within the different counties. We have our community-based organizations. So this could be care managers or other community-based organizations, our schools, our courts, and also our county's social workers. So again, I think the reason I like to point out this slide is that we know that there's a lot of different departments internally, externally that are touching these families, and so ensuring that we have a collaborated effort going forward is where we're looking to see our work for KP. Next slide. So just wanted to go into a few, and this slide is ever growing because I think, with our population, we do see that there's very complex needs. And so my role as a child welfare liaison, to the top, we have local engagement and participation. So I do attend some collaboratives. I do attend the statewide task force for foster children. I'm also attending a lot of the different county collaboratives, and I'm also sitting at the table for the child welfare MOU discussions, as Love and Roger spoke about earlier. And to the right, we have where this is my daily job, is really looking at different issues that come my way. So I am connected with several folks on this call, Jessica Middleton, we have Tori Harder. So there's a few folks on the call today that I've worked with as different issues come across my way as pertains to our foster children. So issues, and this list has grown since we put together this slide, but some of the issues that I've helped to support are changes of address, ECM eligibility and enrollment, KP enrollment, updating legal documents, obtaining medical information, scheduling appointments. We have a lot of Bright Futures concerns. We've had a few folks children that have had drops in medical coverage. The JV 220 form, the psychotropics form that the courts have to sign off on every 6 months. We've had a few glitches within getting those signed. Validation of coverage. Recently, we've also had where one of our foster youth was traveling from, a Middle East, and they had a medical emergency. So when they arrived in New York, I was able to help navigate the family to ensure that they had a place to receive medical services, because in New York, we don't have any KP facilities there. So I was able to get them a contracted facility, so they were able to get some service. So this list goes on, but again, I'm connected with several different counties. All 32 counties have my phone number and my email address, and so I'm here to support if there's any glitches within the system and getting our foster youth and our families the services that they need. To the left, we have care coordination and care delivery. So I do connect internally and externally to ensure that there's referrals and appointments made. Again, I've helped with enhanced care management authorization and also service coordination. And then I believe that, by the work that I do, I'm just advocating for not only the foster youth, the child welfare involved youth, and their families. All right, next slide. So now I'll go into two different member stories. The first member story was an internal referral to me, and so I'll go into this one, and then the second one will be an external member story. So this member story was an internal from one of our child abuse prevention pediatricians. We had 3 African American siblings with housing instability due to death of a family member. For sibling number 1, the sibling had suicidal ideation, untreated ADHD, poor dental hygiene, uncontrolled asthma, and this particular sibling had adopted the parental role because the family was going through so many transitions. So it was pretty much the older sibling that was the constant for the family, for these 3 siblings. And sibling number 2 had unaddressed swallowing dysfunction. Sibling number 3 had suspected developmental delays and suspected hearing loss due to trauma. And this family did present to me with KP HMO coverage through their biological parent, and their foster family, the mother only spoke Spanish, and the father, who spoke English, was in the home but was accessible after 5 p.m. Just kind of setting the stage as to kind of what the presenting factors were, and then I'll walk through on the next slide the steps that I took. So the first step I took was the KP Medi-Cal enrollment. So I called the DHCS ombudsman. So I should preface this by saying that the county social worker and the team was able to put in the KP enrollment. So I then escalated this enrollment to be active as of that current month with the DHCS ombudsman. And then for this particular county, there was some education opportunities. So I did talk to the CPS social worker to review ECM and its benefits to the family. And so once I was able to give that information and education, and as well as some resources for not only the CPS worker, but also the family, I then went and had a cross-agency team meeting. And so we scheduled a meeting with our KP child abuse prevention pediatrician. I was able to get Full Circle, our network lead entity, on the call, and then so we had a discussion to talk about the case, so we can understand what the needs of the family was, and so we can properly match this family with an enhanced care management lead care manager. Then I worked with some internal team members to ensure that we had all 3 kids authorized for enhanced care management services. And then next we had a case conference between our newly established team. So the county social worker, Full Circle Network, and to include the newly paired Spanish-speaking lead care manager, and then we had our internal KP team there as well. So our child abuse pediatrician, we had our healthcare coordinators and such. And so we wanted to provide as much information to lead care manager just to kind of give some background story and which could also help inform her assessment. And then there was outreach to the family, successful outreach to the family based off of not only the CPS social worker understanding what enhanced care management services were, but also from our team, our KP child abuse prevention team, giving the family some information as well. And so in the last column, I do have where we have stayed connected, at least on a monthly basis since this family was connected. But we were able to note that that there have been all three siblings have been linked to counseling. And then also sibling number 3 was linked to audiology and speech therapy. And then I'm sorry, sibling number 1 and 2 were linked to La Familia counseling for ongoing counseling services. And so I wanted to summarize some key highlights from this story that we are able to share. So all three siblings were transitioned back to their biological parents. And we know that when the lead care manager was working with the foster family, there was a lot of great work happening. But we also know that when the children do transition back to their biological or their previous home unit, that's where the work needs to continue. And so we do have reports back from our lead care manager that is making home visits every other week, and on the off weeks is calling the family on those off weeks. And so she's even more connected with the family now that they're back with their biological parents. We do know that the birth mom is now receiving 2 types of services. One to include voluntary parenting classes. All children are receiving counseling services, as I mentioned earlier in the progress update. They are all enrolled in the 2025 school year, and they were getting some educational support. And then our ECM lead care manager and county social worker are in close and constant collaboration. And I have seen this myself, where we're staying connected via email because they do have to stay coordinated and to ensure that there's no duplication of services and that they're working side by side with this family. And one of the biggest pieces of the story was that when the kids transitioned back to the home, the father, who was a little bit hesitant to be on board with parenting and anger management classes, is reported to being completely invested in his course of care. So we do have reports that he is engaged in his anger management classes and is also accompanying mom with some of those voluntary parenting classes. All right, it's all advanced to the next slide, where I believe we start with our other member story. So this one came as an external referral. And so this was a 5-day-old born in the county hospital and removed from birth mom's custody. She was automatically enrolled in Medi-Cal fee-for-service, but the foster parent, who was maternal uncle, lived out of the county. And so being that this baby was born in that she was born in the county hospital, all of her follow-up visits were scheduled in that same vicinity, which was 2 hours away from the foster uncle, or the foster family, which was the uncle. And then the foster parent, which is the uncle, was a KP member, so he was seeking KP assignment for the baby. And then because the baby was receiving services in her county, we needed to find some urgent lab. We need to get her some urgent labs done with our KP team. So next slide, we'll talk about what I identified as the needs for this particular 5-day-old. And so we needed to get her enrolled into KP Medi-Cal. We needed to make sure she had a local pediatric care team identified, so PCP. And then we needed to have her labs and her child well visits continued. And then we needed to make sure we had an integrated care team to continue ongoing services. So here are the steps that I took. So I called the KP Member Services to have her assign a non-member MRN so that we can get her a chart as well as start getting her assigned to a pediatrician. I then coordinated with the county public health nurse and the family to understand where their preferred office location was, and we also received court documents at that time in case there was any glitches within the system when they got to their appointment. Which I found out that there weren't any questions asked when the uncle presented at the appointment. I then called the appointment line to get the baby an appointment and emphasize the need for the bilirubin labs. And then I had an internal chat with the doctor that was assigned to this family, and I started to give the care team as much information as possible that would equip this care team for this family's transition from one county to the other and receiving services. Then we had post-appointment messages. So after the successful appointment, we made sure that we stayed connected, and I was able to link back with the county public health nurse, let her know that this this appointment happened and that this care team was going to be moving forward with this particular 5-day-old, sorry. And then we also had some exchange of information and release forms that were also signed, internally and externally completed. And then we were able to collaborate and give updates because I know that there is that health education passport that is needed by the county. On the next slide, we have our outcomes. So the newborn follow-up appointment was scheduled within 24 hours with a new physician. I did list all of the appointments that were scheduled and that were successful for this family as it relates to this this linkage and receiving this inquiry from our county. And then we have successful reassignment to the pediatrician. So initially she was seen by a general provider, and then we were able to get her assigned to an actual pediatrician so that she can continue her well visits. And then KP enrollment was complete. Her newborn records had been centralized at KP, and I did note that she has a physical assessment. Physical therapy assessment that is scheduled, and that's something that they're addressing currently at this time. So essentially, well-linked baby. Thanks to the county for providing us with this member that needed to receive services right away, and so was able to get this family connected and ensuring that they're receiving ongoing care at this time. And so on the next slide,
Do you mind, Ola, we do have some questions that came in the chat. I don't know if you want to address
absolutely.
those now.
We can address them now. Let's see. Is there a CAS pediatrician located in each of the counties that you serve? I believe they're regional. I can see if I can get a breakdown for which CAS pediatricians serve which counties. Gina, do you know offhand which ones are assigned? I know that I've seen a map, but I can provide that.
I would say yes. I mean, we have wherever we are located, wherever we have this, our commercial footprint is where we also have our Medi-Cal footprint. So in order to do that, we have to have accessible primary care physicians. So I believe that we do. I can double check if you'd like, but we have those locations based on our footprint, which does have geographic considerations. And Vanessa might know more than I do. That's how I would answer that question.
Thank you, Gina.
Mm-hmm.
And happy to take this one back, Vanessa, if we don't have it readily available right now.
Yeah, that sounds great. And Gina, my understanding is the same as yours, but we can confirm with the group. Ola, if you wouldn't mind circling back, that'd be super helpful.
Will do. And then can a single foster home have foster youth with different health plans living in the home? My
I believe-
understanding, sorry.
Oh, sorry, this is Gina. I'm saying I think so, yes.
Exactly. That's gonna be my response as well. So thank you. And I have, so Jessica, thank you so much, Jessica. It's been a pleasure working with you as well. And then Justin, are you the only child welfare liaison for KP? At this time, I am the only child welfare liaison. I do have a backup, Maribel Soria, who's on the call as well. But we do have an inbox, and it's on the slide that I'm sharing right now. We have a liaison inbox that comes to all of our liaisons, and so at any given time, if there's any issues, I do have support from a team of liaisons. All right. So on the slide here, we have Kaiser Permanente Child Welfare Liaison recommendations. So essentially, one of my best practices that I can share with the team today is when you are asking me to help with cases. One of the things that we want to do is to confirm if we are looking for this foster family or the foster child to be enrolled in KP. We want to make sure that we've confirmed that they do have Medi-Cal eligibility, and that would be via healthcare options or the AVE system. We also want to confirm that the MCP selection has been made. So if we're looking to have KP to be their managed care provider or health plan, having that selection made, whether it be healthcare options or the AVES. And then I also put to the right Medi-Cal Medical Assistance Services with KP. The families can also make a selection via that phone number as well. And then retro enrollment, I have been assisting with retro enrollments. My understanding is that the family and or the county can also call the DHCS ombudsman to retroactively enroll the member with Kaiser for the current month, especially if we want to ensure that there's appointments scheduled right away. So that would just be a call to the DHCS ombudsman. And that process looks, once that process is achieved, the DHCS ombudsman will then send KP an email. And that's when within 2 days, the member will have a new chart or a new MRI number. And then here, if you guys ever need my assistance, feel free to email. And it's always helpful if you guys can share their CIN number, their name, date of birth, their address that's on their Medi-Cal application. I know that this can sometimes be difficult because sometimes our children are moving from home to home, but it's helpful for me if I do have to call the state. They will ask me to verify information, and then what's on Medi-Cal application is what I need to verify, and then the family's phone number. And I did put some resources to the right. And so we have the Member Services Call Center. That's our KP Member Services Call Center. And PCP selections can be made there. You can also look up the foster family or the foster child's MRM number. Let's see, Medi-Cal Assistance Service, that is a KP number as well. And I mentioned that you all can call there to get assistance with Kaiser's Medi-Cal, and also make selections and receive support. I also included healthcare options. I know that you guys probably already have this information, but I included it here. Again, it's where MCP selections can be made, even outside of KP's being the MCP. And I did provide the MCP, I'm sorry, the DHCS ombudsman's phone number, and that's through DHCS. And that's where I've been getting retro enrollments completed. And then also our Kaiser Permanente appointment line for the North and South to schedule appointments with a provider. And then lastly, I have my information there as well. So a few of you do have my direct email address. But there's also our general liaison box, just in case I'm out of town or out of the office. And then my phone number is linked there. And again, the best way to reach somebody would be the liaisons chat. Because again, if I'm out of the office, one of my colleagues will be able to support. And that's any issues related to our foster youth or child welfare population. Thank you so much for answering the chat. In counties where Kaiser does not have a physical office, where does a member go for care? And so we do have a list of out of network provider list. And so because it's an ever-changing list, whenever there is a question as to is there a contracted provider, meaning a non Kaiser facility, but we've contracted with a network provider, they can, the county can reach out to me and I can check our updated list to see where the family can go for care, for services. Great, next slide. And so one of the pieces of work that I'm doing right now is we do have our ECM and child welfare presentations that we've scheduled. And so essentially, Vanessa's team, the local engagement team, myself, and Full Circle Network have been partnering to provide a presentation on specifically how our enhanced care management services, community supports, as well as our community health worker benefits would specifically benefit our child welfare populations. And so we have a member story that helps to kind of walk through what types of service, like the service, as well as what types of linkages will be made, how they're connecting with our our different care teams and different services. And so we have been doing those road shows. And so we have completed Orange County, San Diego, Riverside, and Imperial. We do have scheduled Sacramento, Yolo, Sonoma, Santa Clara, and Solano. And then I do have some pending scheduling for Alameda, Contra Costa, San Mateo, Placer, Santa Cruz, which I heard from this morning. So I think we'll have them scheduled by end of day, and San Bernardino. And the list will grow, but essentially this is a roadshow for us just to really talk through specifically enhanced care management services and really how do we break down the different supportive services that the lead care manager can support alongside our county partners. And I have a question. How does a county request to also be on the schedule for presentations? Every county will get this presentation, and so feel free to reach out to me. The way that it's been working thus far, and I probably could have had a slide on this, but essentially I'm working hand in hand with our MOU team, so Roger's team, and once we do our launch, our kickoff, and I should say Roger and Emily Daniels Love's team. Once we do our kickoff, I'm introduced to the teams, and that's when I'm trying to connect to the right child welfare departments or leads, so we can get those presentations scheduled. So please reach out to me via email, and I can ensure that I'm talking to the right folks to get a presentation scheduled. All right, next slide. Excuse me. So our next steps, and so I think next steps could be a longer list of next steps, but this is really within my, my more urgent next steps as relates to our foster youth is really continuing with our county presentations on how our Kaiser Medi-Cal services and those, enhanced care management services would benefit our child welfare population and their families. I'm working with the different counties to identify how we can quickly identify who the county social worker and public health nurses are, so that when we are providing these enhanced management services, that we are continuing to keep as we stay coordinated in these efforts. And then also I'm also reviewing, like for example, we had this conversation with Santa Clara. I know Jackie, I saw you on the call earlier today, but reviewing our foster youth aid code assignments per county. So really looking at the different aid codes and really looking at what our strategic next steps are per county. So again, our adoption assistance program families may have a different approach than our current foster youth and also our current former foster youth. So we're identifying how to really tackle how to stay connected and coordinated as relates to services that we can provide from Kaiser. All right, I believe that may conclude my presentation. Do I have any other questions prior to handing it back over to Vanessa?
All right, and forgive me here as I click through this. There we go. Yeah, Vanessa had to drop, but yeah, I think this is the part where we're going to get to the Q&A session here. And sorry, I know you just opened up the Q&A, but I know we've got a number of our Kaiser Permanente folks on hand here to help answer direct questions regarding anything around MOUs, around implementation. We've also got great leadership here to just explain a little bit more about the program. So yeah, please, I think we'll just take this as an opportunity to open up the floor for any broad conversations or questions. And thank you.
And
all.
if we can take down the slide so that we can see everyone, that would be great too.
Good. And I'll paste this in the chat, that way you know who's here. Yeah.
Right. So if you have a question that you didn't put in the chat, a comment, a thought, please go ahead and raise your hand and I will get to you. Okay, go ahead, Akia.
Hi, good morning. So thank you for that presentation. One of the slides that mentions legal documents, I do have a question, and I'm sure you may have heard this, because for child welfare, there are times where our court will want updates from the actual provider, and they will want that provider to actually come to court to give a report or to testify. So my question would be, with this, would there be any barriers to having your providers or your staff testify?
This is Gina. I don't know. I'm not sure if someone else on the phone does know. I do know that we have medical legal at our local facilities as well as regionally and likely statewide, but I can take that question back and ask.
Great, thank you. And just for the county's information, I know several of you have been on our other managed care plan meet and greets. We do capture all the questions that are asked during the call in the chat live like this, and then we're asking the MCPs to formally answer the questions, and we will post the answers once they're received back. So we will follow up with these questions that weren't answered today. And then we had a question in the chat. Will the steps noted on the slide be the steps for every ECM? Also, will the liaison be the lead or the lead care manager? And this is coming from Monica Connor with Kings County.
So we are working on formalizing our workflows, and so currently those are the steps that we're taking. But future state, we are looking to ensure that the steps are. So for example, me calling the member services line, we're looking to ensure that we have internally some different touch points that can help provide assistance to me in a more streamlined fashion. So I think that there are opportunities for us to really streamline some of the steps. And so I think that, once we work through our internal workflows and P's and P's, those will be highlighted as the steps to take. But the proper step to take is, if there's any glitch in the system as far as getting our members enrolled, please reach out to me. I'll make sure that we have we can navigate those issues internally. And then also the liaison be the lead care manager or the lead care manager. So the lead care manager, that if they are enrolled in enhanced care management services, it would be the lead care manager that would take point for that particular foster child or child welfare involved youth, and in collaboration with the county social worker.
A question, and it was on one of the initial slides explaining like the care management levels, right? And so we had ECM as the highest level of care management, and then we have complex care management, which I think on the slide it said that level of care management is provided by Kaiser. When a foster youth is assigned to complex care over ECM, what coordination happens with the child welfare department?
Are you able to speak to the complex care management and how they are coordinated with our the counties currently?
If they're in the foster youth system, the question is, how are we collaborating with the care coordinators from the county? Is that what the question is? I'm sorry.
Yeah, if complex care management is assigned to a foster youth, how is that coordinated with the county social worker, the county child welfare social worker?
Right. So, and you're talking about if this individual is not enrolled in enhanced care management, but is in fact enrolled in complex case management.
Yeah, it's my understanding that MCPs could assign complex care management if they identify, some issues.
Yep.
And maybe the youth doesn't need ECM.
Right.
So
Definitely.
how does that
and so
coordination
I think
work?
that this is where I look forward to having the MOU signed, right? Where we can have stronger collaboration. So we do assign a care coordinator for our for those individuals needing complex case management. And what I foresee the MOU allowing us to do is having that ability to share information back and forth, which is a little bit more problematic at this time. So I think that that's a place that we really hope to get sooner rather than later, where our case managers can have strong collaboration with the social worker from the county. Our understanding is that the social worker from the county really is the lead and would have information that we might not know, and that we might have medical information or even behavioral health information that they may not be aware of. So having that collaboration is, I think, exactly where we want to get to.
I think a big piece of that for me, and I think I spoke about it on one of the last slides, is knowing who the social worker or the public health nurse is on the county side. That's one of our next steps, is really how does the complex care management staff know who the actual social worker or public health nurse is, and similarly for enhanced care management services. So we just have to be understand, are we going to be able to share the rosters? And so I know for some counties I do have where I have the roster of social workers or public health nurses, but ensuring that we can identify who their actual assigned care team bars is really where I think we can probably get more crisp on.
Right. And I think at this point we would have ROIs, right? So if the foster parent said, I am connected with the county social worker for this, and this, I would imagine what we do right now is we ask the parent to sign an ROI so that we can share information back and forth. And I think that would be a good interim plan, is to have an ROI on file and to have a case conference with the social work primary lead in the case, and then to be able to have that dialogue.
Great, thank you. And then we do have a question in the chat from Justin with Fresno County. How is KP handling data sharing and interoperability? I imagine as counties sign MOUs and ECM and CS usage increases, the inquiries and case coordination will increase tremendously.
I believe we have our MOU team on the call. Did Emily have to drop? I know she is one that's taking lead on our data sharing with the counties.
Yeah, it looks like we don't have Emily here, but this is Andrew saying from the local engagement team. I'm part of Vanessa's organization as pertains to local engagement. And we are also hearing a lot about the data sharing kind of requirements. Obviously, I can't speak to it from a contracting perspective, but I know that at least across the state and by county, the MCPs have been, from DHCS, right, getting the mandate that, needing to have the data infrastructure for a lot of the like closed loop referral systems and developing a platform to make sure that the handoffs between the entities and the organizations are moving clearly. Those are still evolving. I know that there's a lot of the things that sort through in terms of like the closed loop referral, specifically around the specific data platform. For example, some MCPs have different platforms. I know Anthem uses like Find Help. Kaiser Permanente is working through what is going to be the community resource platform, which uses Unite Us licenses for just making sure that the ECM and CS referrals go through. And then obviously the big part is, right, making sure that the data sharing is available so that we're able to kind of capture all that information, and the counties and the MCPs do have visibility into those cases. But those are still evolving. More to come. I can't provide specifics on where the technology is and the specific contract redlining. But I just wanted to highlight those conversations are still evolving.
Thank you. Anyone else have a question? Like I mentioned, we will be asking the Kaiser team to provide formal answers to the questions that were asked here and answered, but also definitely for the ones that they need to go back and do some research on as well. And so if you think of a question afterwards, we are going to encourage counties to complete a survey. We ask counties to do this survey after each of the meet and greets. And so your participation in the surveys is critical to this. It helps us kind of guide what are some supports and guidance that the county still need as you navigate this new landscape with Medi-Cal and the managed care plans, and how can CWDA and CFPIC support you in that. It allows us, we also, if there is a question that is for a particular managed care plan, we add it to the list of questions that we ask the managed care plan to also answer. And yes, we are going to post all of this information on the CFPIC website. In the email, I will share the website link as well. That is hosting all of these webinars. It's where the MOUs are as well, and some previous webinars that we've done around CalAIM. Great, and Andrea just posted it in the chat. So with that, I don't see anyone with any other questions. Anyone from the Kaiser team want to share any last comments, thoughts before we move to end the meeting?
I think just really want to thank all of you for your thoughtful questions, because we are really figuring out how to be, an effective partner in the community, and we care very much about the population, and we want to remove barriers and make it easier for all of them and all of you. So thank you for your patience, and I I have no doubt that we will deliver and we'll work through any concerns or issues in a way that I think is beneficial to the counties and to our foster youth in general. So thank you for your collaboration.
Thank you.
Julian,